Hello friends, welcome to a session of nervous system. We are discussing cerebrovascular diseases. We already seen what is cerebral infarct, what is transient ischemic attack, or what is small vessel infarct. Now we will see what is intracranial hemorrhage. So when patient came with hemiplegia, it's very difficult to differentiate clinically whether patient is having a hemorrhage or infarct. So for initial work of stroke, it is better to do CT scan, and then we need to decide whether to thrombolize that patient or not. So most of the patient, we can say 70 to 80% patient may have infarct, and which may require thrombolysis, and the remaining part, that is 15 to 20% of patient may be having hemorrhage. And hemorrhage can be hypertensive hemorrhage, it can be bleed in the tumors, it can be because of some underlying coagulopathy, or even it can be because of subarachnoid hemorrhage. So accordingly, the management will differ. In this session, we will consider the intracranial hemorrhage, which is associated with or which is a spontaneous hemorrhage. We will not deal with a traumatic bleed, and the traumatic bleed can present with subdural or epidural hemorrhage, or even in some cases subarachnoid hemorrhage. So today's discussion will be more focused on spontaneous bleed. So it may be a hypertensive bleed or subarachnoid hemorrhage. And in general, what should be the management when patient present with intracranial bleed? So as I told you, the causes of bleed, IC bleed, the commonest being hypertensive hemorrhage. It may be because of head injury, cerebral amyloid angiopathy. It may be because of drugs like cocaine or amphetamine, anticoagulant therapy. So anticoagulant therapy is also one of the very common risk factor because most of the patient who are having DVT or pulmonary embolism, those patients, we put them on warfarin or acetone or vitamin K antagonist, and some patient go on taking warfarin without monitoring PT-INR, or because of some diet modification, the INR may vary, and it may touch up to a higher range of INR, and those patients are at risk of bleed. So the monitoring of INR is very important for patients who are taking warfarin or vitamin K antagonist. Regarding coagulopathy and thrombocytopenia, there are many diseases which can present with thrombocytopenia and coagulopathy, and it may be a cause of intracranial bleed. Again, a brain tumor. Some patient may be old age. Those patients complain of headache maybe starting from last 6 months, and they may neglect that headache. But hemorrhage in that tumor, that patient may directly present to us with stroke, and even the brain tumor can be a cause of hemorrhage. So coming to clinical features, as it's not easy to differentiate, as I told you, it's not easy to differentiate between hemorrhagic and ischemic stroke. But the usual scenario is that in infarct, the maximum damage is at the start of stroke. So in embolic stroke or in thrombotic stroke, the neurological deficit will be maximum at start. And embolic stroke will start improving immediately after that initial stroke. But in hemorrhagic stroke, there will be a maximum damage. There will be a damage at initial part of stroke, but even that damage may worsen in next 30 to 90 minutes because the cause may be hypertensive. So patients start with symptom when there is, we can say, mild amount of hemorrhage, and that hemorrhage may continue if we fail to control blood pressure. So the hemorrhagic stroke ideally go on worsening within next 30 to 90 minutes. So this is very important if you take a proper history, and clinically in some cases you can fairly say, okay, this may be a case of hemorrhagic stroke. The next clinical symptom will be diminished level of consciousness. So we can see it ischemic as well as hemorrhagic stroke. Next will be signs of increased intracranial pressure. So as our cranium is a closed compartment, the excess bleed may present with signs of intracranial pressure, intracranial increased IC pressure. And the commonest symptom being headache, vomiting, or in some cases a seizure. But classically, seizures are not so common in intracranial hemorrhage. So seizures, we can say it is commoner in venous sinus thrombosis or venous sinus thrombosis associated with bleed. So seizure is more commonly seen in venous infarct or venous hemorrhage. So the presentation will differ on what is the site of bleed. And the commonest site of, as I told you, the commonest cause of IC bleed is hypertension. Other than trauma, definitely in era of road traffic accident, trauma is the commonest cause for bleed. But after that, the hypertension is a common cause to present as a hemorrhagic stroke. And if that bleed is in putamen, here you have MCQ. What is the commonest cause of IC hypertensive bleed? So your answer should be putamen. Putamen is the commonest site where you will see hypertensive bleed. And such a patient will present with contralateral hemiparesis and slurred speech. Contralateral hemiparesis because of involvement of your pyramidal tract, and slurred speech is because of your involvement of upper motor neuron pulse of facial nerve. So contralateral plagia or hemiparesis and slurred speech. And if you do a CT scan, you will see a nicely hemorrhage in the putamen. So you need to remember that putamen is the most common site for hypertensive hemorrhage, and this is the commonest MCQ asked in your exam when considering IC bleed or IC hemorrhage. So the bleed may be in putamen or in the thalamic area. There is involvement of thalamus. As we know, thalamus is more related to your pain or sensation. Patients with thalamic hemorrhage later may present with chronic and contralateral pain syndrome. So thalamic hemorrhage, in after a few weeks, we can say he may start complaining of contralateral pain syndrome, and it is classically called as a Dejerine-Roussy syndrome. So this is again your MCQ point. Coming to a pontine hemorrhage. So a pons, a part of brainstem, it's a compact part of brain, and when there is a bleed in pontine area, so obviously you will expect more neurodeficit. So patient will have a quadriplegia. Quadriplegic patient with we can say patient may have a pinpoint pupil. So classical sign of pontine bleed is pinpoint pupil. So here you have a MCQ. If you have a MCQ like what is the cause for pinpoint pupil, and if you have option of pontine hemorrhage, so you should tick on pontine hemorrhage. And you may be knowing what is pinpoint pupil. Pinpoint pupil classically is defined as a 1 mm size of pupil, and these pupils will be reacting to light. And size will be around 1 mm. So that will be a pinpoint pupil, and you should immediately think that this patient might be having pontine hemorrhage. Because of involvement of reticular system, this patient will have deep coma and decerebrate rigidity. Coming to a laboratory and imaging evaluation, as I told you, in a initial workup of stroke, you need to do CT scan, because we have a treatment for infarct in the form of thrombolysis, but you cannot give thrombolysis to hemorrhagic patient. So we need to rule out hemorrhage, and if you give thrombolysis to hemorrhagic patient without looking at CT scan, that those patient may worsen. So CT scan, and yes, you have a MCQ here. CT scan is more sensitive than MRI when considering bleed. CT scan is more sensitive for bleed compared to MRI, and MRI is definitely, if you have an option, if there is a patient present with after window period, that is, we can say after 4.5 hour or 6 hour, you rather than doing CT scan, you can directly go for MRI, which will give more information than CT scan. So coming to a treatment, so this patient most of the time present with high blood pressure, and your target of treatment will be controlling that blood pressure. Just maintain systolic blood pressure less than 180 mm of Hg. So you may need not target 120 mm of Hg of systolic blood pressure. Your target should be at around 180 mm of Hg. So mean arterial pressure will come to less than 130 mm of Hg. And for controlling blood pressure, you should avoid NTG, that is trinitrate glycerin. which is a drug of choice for hypertension which is related to cardiac causes. So just avoid NTG, and your preferred drug should be labetalol or nicardipine or esmolol. So labetalol, nicardipine and esmolol, this should be your choice of drug while treating hypertensive bleed rather than giving NTG. As we discussed already, patient will have increased intracranial pressure. So we have option of mannitol or hyperventilation. Mannitol and hyperventilation will decrease IC bleed and before going for any surgical intervention. This hyperventilation will hardly work for 24 hours. So hyperventilation cannot be a definitive treatment for decreased intracranial pressure. It's just a backup for your further plan. In most of the cases, if there is a cerebral hemorrhage, we need to do surgical evaluation. So coming to a surgical evaluation, so you need to just remember one point here. If the bleed is supratentorial, you may not go for surgical evacuation. But if the bleed is infratentorial, because infratentorial contains cerebellum and brainstem, which is a dense tissue which involves vital centers like respiratory center or cardiac center. So when there is infratentorial bleed, you need to call neurosurgeon immediately, and he may advise immediate surgical evacuation in the form of craniotomy. And if that bleed is more than 3 centimeter, I think even you can directly ask neurosurgeon for surgical evacuation. So it was a discussion regarding intracerebral bleed. We have considered what is hypertensive bleed. Now, spontaneous bleed, other commonest cause of IC bleed is subarachnoid hemorrhage. So subarachnoid hemorrhage. So you should not confuse the bleed start from epidural, subdural, which the commonest cause of epidural and subdural bleed is a trauma, followed by subarachnoid hemorrhage, and then intracerebral bleed and intraventricular bleed. According to site of bleed, the name will change. That if it is outside of your dura mater, we will label it as epidural. If it's under the dura mater, we can label it as a subdural. Epidural, subdural, subarachnoid, intracerebral or intraparenchymal, and intraventricular bleed. So here subarachnoid hemorrhage. Subarachnoid hemorrhage, as you know, most of the intracranial vessels are in subarachnoid space, like ranging from your middle cerebral artery or anterior cerebral artery or posterior cerebral artery. These arteries are in subarachnoid space, and any damage or any perforation to those arteries may be start from aneurysm, and those aneurysm may rupture and will directly present as a subarachnoid hemorrhage. So you have MCQ here. What is the most common cause for subarachnoid hemorrhage? So your answer should be rupture of saccular aneurysm. That is Berry aneurysm. So again, this MCQ, this point has been focused multiple times in MCQ exams. So rupture of saccular aneurysm is the most common cause for subarachnoid hemorrhage after trauma, because trauma is definitely first cause when considering road traffic accident. When we are considering spontaneous bleed, our answer should be saccular aneurysm or Berry aneurysm. And the commonest location. So again, next common MCQ asked regarding subarachnoid hemorrhage is what is the commonest site for subarachnoid hemorrhage. So your answer should be, it may be a terminal part of internal carotid arteries. Terminal part of internal carotid arteries may be anterior cerebral arteries, and it may be a site at MCA bifurcation or top of the basilar arteries. Your terminal internal carotid artery, MCA bifurcation, and top of the basilar artery. These are the commonest location where you will see subarachnoid hemorrhage. I want to include aneurysm of anterior cerebral artery in commonest location of subarachnoid hemorrhage. So if you have option of aneurysm of anterior cerebral artery, you may tick it as a commonest cause of subarachnoid hemorrhage. So it's again a terminal internal carotid artery. Coming to clinical features, being a bleed, patient may give a history, or patient or patient's relative may give history of excruciating thunderclap headache, severe headache. He might not experience that headache previously in his life. So excruciating headache followed by neurodeficit or sudden loss of consciousness. So your first differential diagnosis should be subarachnoid hemorrhage. And if you try to check clinical features, patient may be comatose, patient may be in a loss of conscious state. And if you check neck stiffness, there will be neck stiffness positive. So it indicates meningeal irritation. So that bleed as I told you is in the subarachnoid hemorrhage, and the other substance which is present in subarachnoid hemorrhage is CSF, cerebrospinal fluid. So you will get blood in the cerebrospinal fluid, and as that blood will moving around the course of CSF, that blood will irritate meninges, and when you check neck stiffness, patient will have that positive neck stiffness. And the beautiful bedside test for diagnosing subarachnoid hemorrhage, when your clinical suspicion is very high, you just need to do lumbar puncture test in a setup where CT scan is not available. But if there is availability of CT scan, better go for CT scan or imaging. But when there is no availability of CT scan, just do a LP, and if you find blood in CSF, your diagnosis of subarachnoid hemorrhage will be confirmed. Here we have 3-4 important points, clinically interested as well as your MCQ point of view. Some patient of subarachnoid hemorrhage, so patient may not present with subarachnoid hemorrhage, so patient may be having aneurysm of at the junction of PCA and ICA, that is posterior cerebral artery and internal carotid artery. At the junction of posterior cerebral artery and internal carotid artery, if there is an aneurysm at that junction, so that aneurysm may lead to subarachnoid hemorrhage if it's not treated at proper time. Because of vicinity of third nerve, patient may present with third nerve palsy. So before presenting as a subarachnoid hemorrhage, this patient may come to you as a third nerve palsy, maybe ptosis or pupils not reacting to light. So patients who present with third nerve palsy, you need to think of aneurysm, and that patient may soon develop subarachnoid hemorrhage. So this is very important point. You have a ask MCQ as if the aneurysm is at the junction of PCA and ICA, patient will present as, so your answer should be third nerve canal palsy. So similar thing happen when there is a aneurysm in cavernous sinus. So cavernous sinus is again closely associated with sixth nerve. So patient will have a sixth nerve, that is abduction palsy, and patient will have lateral gaze palsy. So again, that patient before presenting as a subarachnoid hemorrhage, he may present with sixth nerve, clinical features of sixth nerve palsy. Again, some patient may present with visual field defect when there is expanding supraclinoid, carotid and anterior cerebral artery aneurysm. So here again you have a MCQ. Aneurysm at posterior inferior cerebral artery, that is PICA, or ICA, means anterior inferior cerebral artery. Aneurysm of this artery may present with occipital and posterior cervical pain. If those patients are not responding to your regular treatment, you have done all workup for headache, so you may need to go for angiography, which will definitely show aneurysm of PICA and anterior inferior cerebral artery. They can present as occipital and posterior cervical pain. Coming to a complication, as such, subarachnoid hemorrhage itself is a complication for aneurysm. But those patients may deteriorate further because of re-rupture of that aneurysm, or patient may develop hyponatremia, or patient may have hydrocephalus or vasospasm. So hydrocephalus, again, as that blood will be in subarachnoid space along with CSF, and that blood will move along CSF, that RBCs or lysed product of blood will block a normal channel of CSF circulation, and so those patients may present with hydrocephalus, and over a period of time the clinical condition of that patient will deteriorate. So this may be a complication. And second thing, vasospasm. Vasospasm, it's basically protective phenomenon of our body to control bleed from aneurysm. So the artery which is prior to that aneurysm will have vasospasm, And this vasospasm itself may be a complication which will lead to ischemia or infarct to area which is supplied by that specific artery. So vasospasm should need to take care. So coming to a diagnosis, as I told you, the diagnosis we can do it with the help of lumbar puncture, and you will see blood in the CSF, and non-contrast CT scan will definitely throw on your diagnosis. Coming to management, we have a two options, that is surgical management, which will be a definitive management, and medical management. Medical management, we need to do it earlier in the course of SH, and as the availability of neurosurgeon, you can go for clipping or coiling. Clipping can be done by neurosurgery, coiling may be done by interventional neurologist. Coming to medical management, the blood pressure monitoring is very important, because high blood pressure will increase subarachnoid hemorrhage, and low blood pressure with the help of vasospasm will lead to infarct. So the blood pressure monitoring is very important, followed by management of vasospasm and treatment of hydrocephalus. So hydrocephalus, so we may need to do ventriculostomy. And in most of the time, it's very difficult to gauge what is the intracranial pressure. So you need to do ventriculostomy to measure the intracranial pressure. And accordingly, we can lower blood pressure to normal using nicardipine, labetalol, and esmolol. To maintain adequate cerebral perfusion, you need to target cerebral perfusion pressure to 60 to 70 mm of Hg. So cerebral perfusion pressure, which can be calculated with the help of systemic pressure and intracranial pressure. So difference between intracranial pressure and systemic pressure will decide what will be the cerebral perfusion pressure. So cerebral perfusion pressure, we need to target it at 60 to 70 mm of Hg. As I told you, vasospasm is again dangerous complication, and the beautiful drug we have in the form of nimodipine, we need to give it 60 mg 4 times in a day, will take care of vasospasm. Next, we can say old type of therapy, that is triple H therapy. So triple H, 3H indicates hypertension, hemodilution, and hypervolemic treatment. So hypertension, as we have a logic that if there is a decreased pressure in that specific artery, that artery will give rise to infarct. So we need to give pressure support by giving pressure drugs or inotropes in the form of your dopamine or noradrenaline. So hypertension, in some cases you need to induce pressure, and in some cases you need to control blood pressure. Second thing is hemodilution. So hemodilution, you need to give more fluid therapy to decrease thrombotic complication. And again, hypervolemic treatment will again in the form of giving maximum IV fluid. It will form a triple H therapy, that is hypertension, hemodilution, and hypervolemic treatment. So for giving this triple H therapy, you need to monitor IC bleed as well as systemic blood pressure as well as central venous pressure, that is CVP. CVP will guide you how much fluid you need to give. Ventriculostomy or IC pressure measurement will guide you what should be our ideal blood pressure. Next, and common management for bedridden patient is prevention of pulmonary embolism. And here, because of difficulty of IC bleed, we have option of preventing pulmonary embolism by giving pneumatic compression stocking. So it was a discussion regarding IC bleed. Thank you.